your data showed really promising cancer results in terms of, I mean, arguably results that are better than we see with neoadjuvant in the bladder in terms of, disease response to this neoadjuvant therapy.
Yeah, we showed, so our group showed roughly about an 18% PT0 rate, meaning that there was no cancer in the kidney at the time of nephroureterectomy. In fact, in the first couple of cases where we had sent patients over and we had these results, I was getting calls from our pathologists who were alarmed that they didn't find any cancer in the specimen, and we had to go back and confirm that in fact that was the right kidney and so forth. But this also corroborates data from the ECOG-ACRIN paper that came out looking at neoadjuvant. They were not able to complete their trial fully. That trial was partially accrued, but they also showed roughly about a 12 to 15% PT0 rate in their series. So I think what that helps us to understand is that with this platinum-based regimens, that we can have not only effective control of the tumor locally, but what we also saw is that patients who responded, so the responders, which were classified as PT2 or less than PT2, sorry, after surgery, that those patients went on to have a much better overall long-term survival. And that was, I think, unique about our paper that they didn't have in the ECOG-ACRIN group, and that was that we were able to show survival data because our trial lasted so long, that we showed that those patients who were responders actually did much better than the non-responders in the study, and suggesting a very strong clinical benefit to those patients. And I would just sort of add on top of that, when you asked about before about why the interest in terms of where we are right now, and that's because I think some of the regimens are changing now. We're now interested in immune-based therapies, and what's unique about upper tract, which is also I think part of the guidelines that people really need to be aware of, and I'm telling people about this all the time now, and that is that in the guidelines we've made a specific point of letting people know that Lynch syndrome is prevalent amongst patients with upper tract disease. So it's one of the upper tract urothelial carcinoma is one of the Lynch syndrome cancers, including with endometrial cancer, gastric cancers, colon cancers, obviously, pancreatic cancers. But what's interesting about Lynch syndrome cancers is that because they have so many mutations within them, because it's a mutation in a DDR gene or an MMR gene, which is a mismatch repair gene, these cancers have so many mutations in them that they are really responsive to immunotherapies. And so now that we're in the era of immunotherapies, especially medications like pembrolizumab that are now approved for patients with urothelial cancer, there's a lot of interest in looking specifically at this population of upper tract patients because there's a high prevalence of Lynch syndrome amongst patients with upper tract.
Yeah, and that corresponding microsatellite instability really gives us that broad approval back to the old indication for pembrolizumab that's site agnostic.
Yeah.
And so I think one of the interesting dilemmas about neoadjuvant therapy is patient selection, because in bladder cancer with a TURBT we can do a pretty good job of staging, and one of the troubles in upper tract is getting that accurate evaluation of disease extent. And so I'm wondering how you approach this clinically, or the insights you can give in terms of how we evaluate the right patients to get neoadjuvant therapy, knowing that our pathological tools pre-surgery are limited.
Yeah, it's very hard to stage patients in the upper tract, unlike with bladder, where we can go in and do a good clinical staging with a TUR. In the upper tract, we really just have the ability to take small samples. So the AUA guidelines did address this, and we've stratified patients into different risk categories. And the risk categories are basically high risk versus low risk. High risk is based on grade, so high grade cancer equals high risk, low grade cancer equals low risk based on biopsy. We also use cytology to help substratify that risk to some degree. So even a patient with low-grade biopsy but a high-grade cytology falls into a slightly higher risk category in patients with upper tract cancers. So what do we have to use then in upper tract? We have to use other adjunctive, what we call biomarkers, I guess, based on things like imaging and other findings. So any evidence of obstruction in the upper tract indicates a higher stage disease. So patients who have hydronephrosis or even obstruction within the kidney indicates a high risk invasive cancer. So among the high grade group, which is high risk, there's high risk favorable and high risk unfavorable. And unfavorable features would be evidence of obstruction, multifocality, sessile tumor architecture on evaluation. All of those have been associated with more advanced and more invasive cancers. However, what we would say is that really for all patients, because of this issue of our limitations in terms of being able to stage patients, that we would say that all patients with high-grade upper tract cancer, based on either biopsy or cytology, should really be offered neoadjuvant therapies up front prior to nephroureterectomy. And I would say that's particularly important in patients who have underlying CKD or poor kidney function, because those patients are much more limited in terms of what they'll be able to receive after you take their kidney out. Some people have asked me, say, well, are there any patients that you wouldn't necessarily offer neoadjuvant to who have high-grade disease in the upper tract? And I would say, you could certainly make that case for somebody who has excellent renal function. Maybe their underlying GFR is over 90, and taking out one of their kidneys is not going to land them, on that, in a situation of a CKD or an eGFR less than 50. Or maybe even potentially some patients who have, say, tumors in the lower ureter, and you're planning to do a ureterectomy and a reimplant. Those, since you're not taking their kidney out, you could always wait for what the findings are at the time of pathology and then treat them accordingly to the POUT data.